Anion gap is a very frequently encountered clinical scenario, and residents often do not know the basic concepts behind it. Metabolic acidosis, as we know, is pH less than 7.35 and bicarbonate values less than 20 millimoles per liter, and it can be of two types: anion gap metabolic acidosis, which is also referred to as high anion gap metabolic acidosis, and non-anion gap metabolic acidosis. So when we see the normal distribution of ions in plasma, we find that amongst the cations are positively charged ions, as we know from our school days of chemistry. The major cation is sodium and the other one is potassium. So these two are the cations which we measure at the bedside of a patient in an ABG. Magnesium and calcium we generally don't. Ionized calcium we monitor, but generally sodium and potassium are the values which we can monitor or measure at the bedside. Similarly, when we talk about anions, chloride is the major anion in the plasma, and this value we can measure in the ABG, as well as the value of bicarbonate. So normally these cations, that is positively charged ions, and these anions, that are negatively charged ions, these are in a state of electrical neutrality or homeostasis. To maintain the homeostasis, they are in a state of electrical neutrality. So what actually is anion gap? It is given by the formula sodium minus chloride plus bicarbonate. But most of the laboratories and many of the books, they also mention that anion gap is calculated by sodium plus potassium ion minus chloride plus bicarbonate, that is measurable cations minus measurables anions. So if we are calculating the difference between cations and anions, then why is this not known as cation gap and why is it this known as anion gap? So this you must think. Now what happens is that normally this is the normal distribution of cations in plasma and the normal distribution of anions in plasma. We see that to maintain the electrical neutrality, this amount of cations are slightly more than these amount of anions. So this is referred to as, basically this is the value of unmeasured, this value of the cations which we can measure is actually equivalent to unmeasured anions. If we see, if we draw a line over here, then we see then this value equates to a value of unmeasured anions. So that is why the anionic gap which we calculate is actually a cationic gap, but the surrogate of this is the anion gap, and this is because of the unmeasured anions. And normally also this exists even in normal persons. When there is no acid base disturbance, this anion gap does exist, and this anion gap in them, the value of this is between 4 to 11 millicoulombs per liter, as mentioned in most of the books. But generally a value of plus minus 12 plus minus 2 is taken to be as the normal range for normal anion gap. Now what happens is that in patients with metabolic acidosis, sometimes what happens is that the bicarbonate levels decrease, that is they shift from this level to this level, and the chlorides they increase compensatorily. So what happens is that the anion gap, it still continues to stay the same as was in a normal person. So this kind of metabolic acidosis, in which the bicarbonate has reduced and therefore the pH value has also reduced, but the anion gap continues to stay the same, is referred to as normal anion gap metabolic acidosis, and it is also referred to as hyperchloremic metabolic acidosis, because the chloride values have increased to compensate for decrease in bicarbonate. Now in some cases what happens is that the bicarbonate values, they do decrease, and because of this the pH decreases. But what happens ultimately is that this gap, that is the anion gap, a difference between the cations and the anions, it increases by this much. Why? Because the unmeasured anions have taken place in the plasma. So these unmeasured anions contribute to what is referred to as anion gap, increased anion gap, sorry. It is referred to as increased anion gap, and this is what is referred to as increased anion gap metabolic acidosis or high anion gap metabolic acidosis, that is AGMA or HAGMA. So the normal value of this anion gap is between 4 to 11 milliequivalents per liter, as I already told you earlier. But most of the time, an average of 12 plus minus 2 is taken to be the normal. There is a variation amongst the laboratories, and this normal value between 4 to 11 MEQ per liter is considered to be secondary to the negatively charged anion albumin, which is normally present in the body of human beings. So one must also know what happens if there at all is hypoalbuminemia. So anion gap decreases by 2.5 milliequivalents per liter for every 1 gram per deciliter decrease in albumin. Or in other words, you can remember 2 for 1. 2 for 1 means anion gap decreases by a value of 2 for every 1 gram per deciliter decrease in albumin. 2 is actually equivalent to 2.5 if you want to be more precise and accurate. So in these patients, an adjusted anion gap has to be calculated to account for decrease in serum albumin, and this adjusted anion gap is given by the formula anion gap plus 2.5 times normal value of albumin in the body, that is 4.4, minus observed albumin, and this formula is what is referred to as the Figge's formula. It may sometimes be asked in your exam, stable viva especially. Now, there are certain clinical scenarios in which you can get this high anion gap kind of metabolic acidosis, and we can commonly remember it with a mnemonic which is referred to as trickle. So the common causes of increased anion gap metabolic acidosis are toxins, then renal failure, some cases of inborn errors of metabolism, ketoacidosis, which is generally diabetic ketoacidosis seen in children, sometimes starvation ketoacidosis as well, and lactic acidosis, which is the most common cause of high anion gap metabolic acidosis encountered in children. In lactic acidosis, there is endogenous production of lactic acid, and this breaks into hydrogen ions, which are positively charged cations, and lactate ions, which are the anions. These hydrogen ions, a part of them get buffered by bicarbonate, which neutralizes them, but the remaining unbuffered part, it leads to a decrease in pH, as we know that pH is the log of the inverse value of hydrogen ion. So hydrogen ion is directly related to the calculation of pH. Lactate ions, anions, on the other hand, are responsible for increasing the anion gap. So in short, I have explained what actually happens in anion gap metabolic acidosis if it is a lactic acidosis. But in other cases of increased anion gap metabolic acidosis also, the initial step is generation of hydrogen ions, cations, and the unmeasured anions from the parent compound. Now, for example, in diabetic ketoacidosis, ketoacids like beta hydroxybutyrate and acetoacetate form in addition to cations. Unmeasured anions in case of renal failure are phosphates, urates, and sulfates. And in some cases of renal failure, a mixed anion and a non-anion gap metabolic acidosis exists, since increased unmeasured anions is less than the decrease in bicarbonate levels. See, unmeasured anions, this is the pathology of increased anion gap metabolic acidosis, and pure decrease in bicarbonate levels is a pathophysiology of hyperchloremic metabolic acidosis. So what I mean to say here is that this is, for example, anion gap metabolic acidosis. In some patients of renal failure, anion gap does increase, but this increase in anion gap is slightly more than the decrease in the bicarbonate value. Increase in anion gap is more than the value of decrease in bicarbonate. So this actually happens because of tubular disorders, when renal failure is seen due to tubular disorders like renal dysplasia, obstructive uropathy, because of coexistent renal tubular acidosis in these patients. Some kinds of poisoning also have unmeasured anions which lead to increased anion gap metabolic acidosis. For example, in methanol poisoning, formate is there, in ethylene glycol poisoning, glycolate is there, and in salicylate poisoning, lactate and keto acids are there. So in short, calculating the value of anion gap helps you to narrow down the differential diagnosis in patients with severe acidosis. Some patients of inborn errors of metabolism also have an increased anion gap metabolic acidosis, commonly seen in patients with organic acidemias and defects in pyruvate and ketone metabolism. Now, mixed anion and non-anion gap metabolic acidosis, as I've already discussed, in some patients with renal failure, may also be seen in some other cases, for example, in patients with diarrheal dehydration, where hyperchloremia also occurs and lactate can also increase because of severe dehydration. Then in renal failure, especially due to tubular disorders, as I had discussed earlier. And some patients, they have two causes of increased anion gap metabolic acidosis, like diabetic ketoacidosis coexistent with renal failure. This is a tough scenario, and I have seen around 2 to 3 patients of these in the past 4 to 5 years. So in these patients, you must remember that an anion gap must always be interpreted in light of other clinical and laboratory findings and should not be looked at in isolation. So next, how do we know whether AGMA and NAGMA coexist in a patient, or whether two causes of anion gap metabolic acidosis exist in a patient? So the answer to these questions is by the calculation of the delta gap, and this I shall be discussing in a subsequent video of mine. So thank you so very much for a patient listening and watching, and please do share the video for maximum benefit of all students. Thank you so very much.